Hello, good evening, and welcome to the Facebook Live Talk. And thank you for joining us tonight. My name is John. I will be the host for tonight's program. Okay, before we start, a brief program outline. First, we'll have a brief introduction of ourselves and also the co-organizer, then the talk, and we come to the Q&A questions. For the Q&A question, please prepare a question and put it in the comment section, and we will address the question when during the Q&A segment. So then, okay, 365 Cancer Prevention Society, in short, 365 CPS, is established in 2003. We focus on creating awareness, cancer awareness. We focus on three pillars, which is cancer prevention, cancer fighting, and cancer education. For more information, you can check out our website, and please support us by giving your likes and follow our Facebook page, Instagram, and Telegram. Okay, next, information on our co-organizer, OncoCare Cancer Centre. It is an independent private cancer center established in 2007. OncoCare provides a patient with quality care services and treatment administered by highly skilled and qualified medical professionals. They have 6 clinics and 1 woman cancer specialist clinic, mostly situated in central Singapore. Okay, for more information, please check out their website and do like and follow their Facebook page. The next, a gentle reminder for the audience, kindly take note that all information shared in this event by the speakers and 365 CPS are for general information only and subject to changes. Do consult your doctors for personalized and detailed medical advice. And thank you. Okay, so much of administrative information. Let's get back to the talk proper. Tonight's topic is lymphoma can be cured. Learn new ways to beat it by Dr. Kelvin Tay. Okay, Dr. Kelvin Tay is a senior consultant medical oncologist with OncoCare Cancer Centre. It is also a visiting consultant at the National Cancer Centre. He's always been active in research and is part of the core group with National Cancer Centre Singapore. Dr. Tay's subspecialties is in women-related cancers, such as breast cancer, gynecological cancer, brain cancer, and leukemia. And of course, lymphoma, which is tonight's topic. So let's welcome Dr. Tay. Okay, good evening, Dr. Tay. Welcome, and we'll pass the time to you. Dr. Tay? Okay, we are experiencing some technical issue. Please be patient and stay with us. We'll come back to you in a short while. We are still checking on the technical issue. Be patient with us. Okay, while we're waiting, maybe we like to just give a brief more info on 365 Cancer Prevention Society. Okay, we have three centers that we have helped. We do activities daily. We got three centers. One is in Amokyo, one is in Clementi, and one is in Bukit Panjang. So daily we have activities, and we do support all those cancer patients by providing them meals. We are about to come back already. By providing meals, yeah, okay. And also the and some activities like drawing, activities like exercise. So if you know of anyone or have someone that needs support, you can always contact us, and you can check out on our Facebook. Okay. We're still having a technical issue. Just be patient with us. Okay, maybe more information on our focus on the three principles we have. One is cancer prevention. Okay, we adopt practical ways to reduce the risk of developing cancer. The next, we have cancer fighting. Provide support for cancer fighters to rebuild their life. and work towards full recovery. That's why I mentioned that we have center that provide activity for them, where we most of them that comes there are fellow cancer survivor and fighter. They support each other. We have exercise and appropriate exercise for them, or on different kind of different kind of exercise that they can come and join the center. They can register with us, and also we do education, cancer education, like promoting wholesomeness and wellness through education. Like we have this live talk. We also have other love lunch talk, and also we conduct many other talks in our Facebook and Instagram, and also in Telegram too. Okay, as I've mentioned, we have what we do is that we have three social service center. Okay, one is in Amokyo, one is in Clementi, and one is in Bukit Panjang. Okay, besides activities, we also provide counseling service that we can attend to individuals that need our advice, need our counseling sessions. Also, besides that, in the center, we also provide nutritional support. The member will come to our center, were able to enjoy one of our nutritional meal provided by our specially trained cook, and also specially trained cook. Okay. Next, we also have care and support team that which we visit the home of a patient that is cannot come to our center, or the mobility they have some difficulties, so that we will go to them rather than they come to us. Okay, the exercise session we have regularly in the social service center. Hmm. Okay, the social service centers, just a bit more. Yeah, okay. Besides exercise, we also have activities in drawing, and also in okay, we got finger painting. We have arts painting, Chinese painting, various kind of activities to support our member who says they want to make themselves, while they are recovering, they want to have some emotional support, so they can come to our center and try, and we have fellow cancer survivor. They can really communicate and make friends. Yeah, as we have said, we have three centers, Amokyo, Bukit Panjang, and Clementi. We have one up and coming, which is now in Tampines, which is now still under renovation. I think it will be up in a few months' time.
Hey, good evening, John.
Yes.
Hello, my friend, and good evening, everyone. Welcome once again to our live streaming show. Yep, so sorry, everyone, that we are having some form of technical difficulties at the moment, but please stay tuned. Yeah, John, I think you just touched on something new for our 365 CPS members, and definitely I think for the residents in the East, I think it's definitely a welcoming sight, to know that 365 CPS is coming to a place, to our community. So yeah,
Yeah.
for our Tampines residents, right, is
Yeah.
it's a good news that you will soon have 365 CPS social service centers coming to your neighborhood soon. Do
Mm.
look out for us soon, right? So, John, you are a manager in charge of one of our SSC,
Yeah.
right, over at
Yes.
Bukit
Mm.
Panjang. Yeah, so maybe you'd like to share with our viewers tonight, right? What are some of the interesting things that you see, and also in your interaction with our very active and happy members, right? So what are the most memorable stuff you can
Yeah, actually, okay.
tell us about?
We, as I said early on, we conduct a lot of exercises. Okay, I think if we have exercises with light and medium intensity.
Mm,
When I first joined the society, I saw the program there, Zumba and aerobics. I was quite surprised that there's such high intensity exercise. But
mm,
after I see those, after I get along, I see those people, members coming in. Okay, those are cancer survivor. They have the full. They okay. I'm not sure whether they're fully recovered, but they are well and healthy, and they can follow the exercise
mm,
very well. So actually, they live quite a normal life as
mm,
any other person without another normal person. So
mm,
this
mm, mm.
part is quite encouraging and ensure that the most it can cancer can be recovered in most
Yeah,
parts. So
that's right.
yeah,
That's right.
yeah.
Yeah, I
So
think I think it's something that all of us get to witness at 365 CPS, whether it's at the center level or at the HQ level, and also in our daily work that we do encounter members that
yeah,
is
yeah,
so-called, very active. One thing I find that they are very infectious. Our cancer fighters, in terms of their joy and their spirit, is very, very infectious. And if you talk to any one of them, they are full of fighting spirits and
yeah,
really,
yeah,
full of
yes,
zest,
yes, yes,
right?
yeah,
So yeah, I mean, we have our Dr. Tay,
yeah.
who has just joined us online now, right? Thanks, Dr. Tay, for making the
Hi,
time in joining us.
hi everyone. Yeah,
Yeah,
thank you for
Yeah, yeah,
waiting.
yeah.
There was some
yeah,
technical
yeah,
issues.
okay.
It has to happen on the night itself.
Yeah,
No problem.
no
We
problem.
fully understand. We fully
Yeah,
understand. I
yeah,
think it's also really a salute to all frontline healthcare workers, like yourself and many others out there who is really holding the fort and really supporting all Singaporeans, in our fight against COVID and
mm,
the so-called deadly or rather really infectious Omicron. So everyone, please take care and stay safe. So I'll hand over the time back to our host for tonight, John, and also
yeah,
look out for Dr. Stay's session. It's coming up soon. All right, over back to you,
okay,
John and Dr.
yeah,
Tay.
okay.
Right.
Thank
Thank
you.
you very much for your patience, all the listener or viewers. Okay, now we welcome Dr. Tay, and we'll pass the time to Dr. Tay.
Good evening, everyone. Again, so apologies for the technical difficulties earlier. Uh, so I am going to be talking about lymphoma tonight, and I was actually talking to myself earlier, not realizing that the connection was off. But tonight I'll be talking about lymphoma, and it's one of the kind of cancers that actually can be cured. And the first half of the topic, I'll be talking about what lymphoma is, how do we normally treat lymphoma, and the second half of the topic, I'll be talking about some of the newer treatment modalities that we can overcome this cancer. So with that said, I often get asked this question by my patients. I always ask my patients, what is lymphoma? The most common answer I get is that it's a cancer involving the lymph nodes, which is not wrong. I mean, but more specifically, lymphoma is really a cancer of the lymphocyte, which is a type of white blood cell. In other words, lymphoma is a cancer of the white blood cell. What does a white blood cell do? A white blood cell is part of our immune system. Therefore, you can think of it, lymphoma is really a kind of cancer of the immune system. All of us actually have two types of lymphocytes, a B lymphocyte and a T lymphocyte. So if it arises from a T cell, we call it a T cell lymphoma. If the cancer arises from a B cell, we call it a B cell lymphoma. So technically, we classify lymphoma into these two major subtypes, a T cell lymphoma and a B cell lymphoma. So this is a slide showing some of the famous people with lymphoma. And on this, we already have two prominent Singaporeans who were diagnosed with lymphoma and are living, and one of them is still living with lymphoma. So lymphoma is really not the most common, but it's one of the top 10 cancers in Singapore. Among men, lymphoma is number 5, and among women, lymphoma is number 6. We have also noticed that there is actually a rising incidence of lymphoma in Singapore. And over the last few decades, we do see a rising trend. This is actually very in keeping with the rest of the developed world. In the US, or in most of the Western population, we see a rising incidence of lymphoma usually among the elderly, more than 60 years old. Why this is so, we don't really know, but it seems to be associated with a more affluent economic status, countries with that sort of economic status. The most common presentation of lymphoma is an enlargement of the lymph nodes. So if it arises in the neck, we call it the cervical lymph nodes. In the base of the neck is what we call the supraclavicular lymph nodes. In the armpit, it's the axillary lymph nodes. In the groin, we call it the inguinal lymph nodes. So you can see that lymph nodes are actually found in different parts of the body. So there are many other lymph nodes that we yet cannot see with the naked eye, or we cannot feel because they're all inside, either in the abdomen or in the middle of the chest. But there are also other warning signs of lymphoma. Most notably is actually the presence of persistent fever. Usually the fever is a very low grade, less than 38 degrees, about 30, between 37.5 and 38, and usually happens once or twice a day. But it persists for a few weeks, even months, before it gets diagnosed. And the other thing that can be associated with lymphoma is what we call excessive sweating at night, or excessive night sweats. This is not a typical hot weather kind of sweating. It's actually drenching night sweats. I mean, the patients will actually know when they wake up, the entire bed sheet is soaked. And also patients may sometimes present with significant weight loss, what we define as more than 10% from their baseline. Obviously, the other symptoms may be associated with whichever organ that lymphoma is affecting. For example, if the lymphoma is affecting the lymph nodes in the abdomen, then patients may present with abdominal pain or even abdominal swelling. If it presents in the chest, lymph node swelling in the chest, in the what we call the mediastinum, then patients may present with a cough or even difficulty breathing. Are there any particular risk factors that predisposes one to getting lymphoma? There are several conditions that can be associated with lymphoma. For example, patients with autoimmune condition like lupus or rheumatoid arthritis. These patients have a small increased risk of developing lymphoma later on. And the other group of patients that can develop lymphoma are patients who are post-transplant, post-organ transplant, for example, post-kidney transplant or post-liver transplant. They all carry an increased risk of developing lymphoma. Then there are certain chemicals, radiation exposure, chemicals in particular, like pesticides, or even in the oil and gas industry, some occupations working in the oil and gas industry, because of exposure to benzene or solvents, these predisposes one to developing lymphoma. You also might be interested to find out there are certain infections that may be that also has an increased risk of developing lymphoma, like HIV, even common bacteria like Helicobacter pylori associated with stomach ulcers. And I'll go through some of these infections. So Epstein-Barr virus is a very common infection, sometimes developing even in childhood. And they're usually very mild symptoms, but with chronic Epstein-Barr virus infection, it has been shown that patients do develop predisposed to lymphoma. For example, NKT cell lymphoma and certain types of lymphoma called Burkitt's lymphoma. The HIV virus is associated with lymphoma affecting the brain primarily, and also a kind of lymphoma called the primary effusion lymphoma of the lungs. This bacterial infection called Helicobacter pylori, it is a it's quite a common infection that we see, but only a very small percentage of patients with this bacterial infection do go on to develop a type of lymphoma called multimedia of the stomach. So the picture on the right you see is the stomach ulcers, the arrow pointing to the stomach ulcers, and then the middle picture with the arrow pointing to the black colored dots, those are the bacteria that we see under the microscope. Again, another bacterial infection, typically affecting around the eye, what we call the orbital mold lymphoma, and it's associated with this bacterial infection called Chlamydia psittaci. So how many types of lymphoma are there? There are many, many different types of lymphoma. So it's not one disease. So this slide really goes to show that 80 different subtypes of lymphoma. And I alluded to you earlier that there are different ways to define lymphoma, but broadly speaking, if you do look up on the internet, lymphoma can be divided into whether they are Hodgkin's or non-Hodgkin's lymphoma. This is a very age-old classification, but it's still useful because we broadly define into whether Hodgkin's or non-Hodgkin's. The majority of lymphoma will be non-Hodgkin's lymphoma, 90%. Only 10% of lymphoma will be Hodgkin's. This distinction is really made by the pathologist under the microscope. So it's not due to any physical condition. It's under the microscope, the pathologists read the slides and they can tell whether this is Hodgkin's or non-Hodgkin's. How do they know? This picture here on the left side, you see the Reed-Sternberg cells. The presence of these Reed-Sternberg cells, we call this Hodgkin's lymphoma. There are only 5 different types of Hodgkin's lymphoma. On the other hand, when we talk about non-Hodgkin's lymphoma, I mentioned earlier, it can either arise from a B cell, then we call it a B cell lymphoma. If it arose from a T cell, we call it a T cell lymphoma. And this forms the majority of all lymphomas. Among the non-Hodgkin's lymphoma, you can see that B cell accounts for the majority, 90% will be B cell lymphoma, and only 10% will be T cell lymphomas. So most T cell lymphomas will be fast-growing or aggressive, and only the skin, the cutaneous T cell or the skin T cell lymphoma, that's slow-growing. On the other hand, the B cell lymphomas again can be subtyped into whether they are fast-growing or slow-growing. Okay, I've listed some of the examples of fast-growing lymphomas called diffuse large B cell lymphoma. That's the most common. And among the slow-growing lymphomas, follicular lymphoma, marginal zone, or another name is called MALT lymphoma, mantle cell lymphoma. These are examples of slow-growing lymphomas. How do we stage lymphoma? So the staging of lymphoma is quite different from the other cancers. It goes by the lymph node position. So if you have one lymph node position or region, one side of involvement, we call it stage 1. If there are 2 lymph node regions or more, but on the same side of the diaphragm, we call it stage 2. Where you have lymph nodes up and down on opposite sides of the diaphragm, we call it stage 3. And stage 4 means that it's gone beyond the lymph nodes, affecting the other organs such as the liver, the lungs, the bones, etc. Okay. So as I alluded to from my title, lymphoma is potentially curable. That's the good part, right? But obviously, the majority of these fast-growing lymphomas actually do well, and there will be a small subgroup of patients who may not. So this is a typical PET scan picture where we, before treatment, the top part of the picture shows the lighted orange area here. Yeah, the lighted orange area here. And that's where the tumor mass is before treatment. And after treatment, you see a complete resolution of the tumor mass. Thankfully, this is the typical picture that we do see with our lymphoma patients. So the important thing to know is that really a lymphoma survival has really also improved over time. If you look at this top curve here, this is the top curve depicting the 5-year overall survival in this type of aggressive lymphoma called diffuse large B-cell lymphoma. And you look at, it was only about 40%, 5-year, that means 40% of patients are still alive at 5 years in the 1970s. But fast forward to 2010s, you can see up to 70-80% of our patients are still alive with this type of aggressive lymphoma. And with the slow-growing lymphoma or indolent lymphoma, for example, the follicular lymphomas, this is the 10-year overall survival. Before the year 2000, 50% of patients will be alive at 10 years. But now, after 2000, 75, 80, 85%, each year the survival rates are improving. So that's the satisfying thing about treating patients with lymphoma. What could have contributed to this improvement in survival? We have better accuracy in diagnosing patients, more accurate staging methods. Obviously, it's a multidisciplinary tumor board approach, better investment in research and education, better treatment, therapy modalities, and also better supportive care and facilities. So I wanted to highlight a few things. The accuracy of diagnosis of lymphoma is really crucial. Very often we get sample biopsies, and the most ideal biopsy is when you take out the entire lymph node so that the pathologists can read the entire lymph node. They can cut out the entire lymph node. If that is not possible for whatever reason, then the next best approach is you just take what we call an incision biopsy. That means take a big bite of that enlarged lymph node, or a core biopsy. A fine needle biopsy is never adequate for lymphoma in making a diagnosis of lymphoma. A fine needle means just a very teeny-weeny needle goes into the lymph node and take it out. That is never a good way to diagnose lymphoma. And obviously, we need a very dedicated, specialized hematopathologist who can read the slides. That would be best. And thankfully, in Singapore, we have these resources in many of the major hospitals. And then again, immunohistochemistry staining is essential in making the diagnosis of lymphoma, because I told you earlier that 80 over different subtypes. Without staining on the tumor samples, you can never tell the difference between the different subtypes. So for example, I give this example of a diffuse large B-cell lymphoma with double expression of c-MYC and BCL2. What does this mean? It just means you don't need to know the details, but you can see the pictures that are in brown, my arrow pointing here in brown. This is a CD20 stain that is strongly positive. And if you look to the bottom left here, the BCL2 again is strongly positive, and this is a positive stain. And the CD3 that is negative is not very few brown cells. Brown meaning it's staining for the color of the tumor cells. You can see this is CD3 negative. So again, different subtypes of cancer of lymphomas will have different immunostains, and this is how we make the diagnosis of subtyping the different types of lymphoma. I mean, mistakes can still happen. I do get a lot of these second opinions from other centers and even other countries, and I get patient A, for example. The patient presented with what we thought was typical symptoms of lymphoma, like weight loss, fever, enlarged lymph nodes. And then when they biopsy the lymph nodes, and it was told to have aggressive lymphoma and you have to start treatment immediately. But when they came to Singapore and I repeated the biopsy and we tested it again, it turned out to be a tuberculosis. So the patient didn't require any chemotherapy or urgent treatment for the lymphoma. Because he didn't have any lymphoma. Another second opinion that I saw, this patient presented with enlarged lymph nodes in the chest and lung masses, and they were told that he had incurable advanced lung cancer. But when they came to see me, I redid the whole workup, and again, it turned out to be lymphoma. So it's very different, right? And lymphoma survival rates are so much better than advanced lung cancer, and patient cannot believe that he has a second chance and able to watch his children grow up. But therein lies the importance of making an accurate diagnosis. And then part of it is also to make an accurate staging of the lymphoma. One of the key things that's helped us in the last few years is that the advent of using PET scanning as part of imaging modality. So the black and white is the regular CT, right? The black and white, I pointed out here, This is the regular CT. The CT is still a good way of looking at the insides, but it tells you the size of the tumor, it tells you the location, but it doesn't tell you the activity of the mass. On the other hand, when we do a PET scan, the picture on the left here, you see that this tumor mass that is shown here is very bright. So the brighter the lesion, the more active the cancer cell is. So it gives us an idea. We also use PET scan to track the response to treatment. So again, the picture on the right, you can see the picture on the right, the top half is a CT scan, and then the bottom here is the PET scan. So when we first started out, there was a lesion in the abdomen. This is the abdomen, the white color. The white color here depicts the tumor mass here. And over time, you can see that the tumor mass actually resolve and disappear. So that's one other way that we use the PET scan, is to not just for the accuracy of the, not just for diagnosing and staging, but also for tracking the response to treatment. So next, I'm going to talk a little bit about how we treat lymphoma. I mentioned earlier that lymphoma is a kind of white blood cell cancer. So, and it's a cancer of the immune system. So I often give the analogy that our immune system is everywhere. So therefore, the backbone of treatment in a cancer like lymphoma is really chemotherapy, a treatment that can go into the system and treat the cancer cells that may be hiding in different places. So surgery and radiotherapy, they are not the forefront of treatment in lymphoma. It still can be utilized, but it's not the primary modality of treatment. So chemotherapy still is the main treatment in treating lymphoma. I always get asked by new patients, how does lymphoma? I mean, how do we administer chemotherapy? Chemotherapy really is like any other fluid infusion. Patients sit on. They come to the clinic. You know, most of the time nowadays, chemotherapy, we do not need to hospitalize patient. It can be done in the outpatient clinic. Patient sits there for a few hours and they go home after that. Some infusions could be shorter, like even 30 minutes, and some infusions are longer. It depends on the regimen that we use, but it's like any other drip. So chemotherapy really, there's the old style chemotherapy, what we call the conventional chemotherapy, and this has been around since the 1950s, where it kills the tumor cells, but it also affects the normal cells, which is why patients do develop side effects. But in the last 2 decades, we have been using more and more of targeted therapy, where it targets the tumor cells and less on the normal cells. And this has been around for the last 20 odd years. So the treatment of aggressive lymphoma incorporates both these strategies. For example, diffuse large B-cell lymphoma. We still have to use a combination of chemo and also targeted therapy. Targeted therapy alone has not been shown to be as effective as the combination approach. So the typical chemotherapy that we use for diffuse large B-cell lymphoma would be the backbone chemotherapy called CHOP, which is actually 4 different kinds of chemo drugs, and then with the targeted therapy called rituximab, which is the antibody. So this is R-CHOP, so rituximab plus the CHOP. It's usually given outpatient once every 3 weeks. So that means patient comes back only once every 3 weeks to the clinic, and each time the treatment can last for about 3-4 hours, and then they go home on the same day. And we give this for about 6 times, minimum 6 times. The treatment for slow-growing lymphoma, like follicular lymphoma, it's a little bit different from treating fast-growing lymphomas. Very often in slow-growing lymphomas, we can even not treat with chemotherapy, just observe. If, let's say, for example, a patient only has very small volume disease on the scans, that means just very small lymph nodes, it's present, we biopsied and came back to be confirmed with follicular lymphoma, but only very small volume on the CT scan or PET scan, we can tell patients, oh, actually we can be observed for a while, especially if you have no symptoms at all. So the decision to really start treatment for slow-growing lymphoma really depends on the symptoms or whether the disease is growing rapidly or not. With subsequent follow-ups, you'll be able to tell. And if you do require treatment, the treatment is usually less intensive chemotherapy compared to the fast-growing lymphomas. So the paradox here is that for slow-growing lymphomas, we are not able to cure them because it's usually a very slow-growing indolent cause, but patients typically have a prolonged survival. It's almost treated like a chronic disease. So a typical chemotherapy regimen for slow-growing lymphomas is a rituximab plus bendamustine regimen, for example. It's also again given outpatient. It is one chemo drug and one targeted therapy in combination. It's given once every 4 weeks, again up to 6 cycles. One cycle meaning 4 weeks. So the next part of the talk, I want to focus a little bit on some of the newer, exciting, novel treatments that we have in lymphoma. So this slide is very busy, but the main thing I want you to know from this slide is that this is the B cell. So this is a typical B cell. This is the, and I told you, we have now through research and advancement in the way we understand the biology of B cell lymphoma, we now know there are several of these proteins or targets on the surface of the B cell that we could potentially develop a drug that can attack these cancer cells. So right now, we have 2 targets that already have drugs, the CD20 and CD19. I've listed some of the monoclonal antibodies on the right here. So it targets this CD20 and this third drug here, tafasitamab, is targeting CD19. How does it work? So essentially, the antibody will recognize this protein on the cancer cells. It binds to the cancer cells and it leads to a few this scenario where your immune system can recognize these B cells and kills off the cancer cells that way. So basically, the antibody is just a target. It targets the cancer cells, and then it sparks off a series of chain reaction, letting your own immune system recognize it and then kills the cancer cells that way. So people have also taken one step further. They have developed an antibody now, and they link it to a chemotherapy drug. So this is the antibody again, and then it is bound to a chemotherapy drug. So what happens is that, again, the antibody is just to recognize the cancer cells. So you recognize the cancer cells. In this case, it's a CD30. You recognize it, and the entire antibody gets absorbed and internalized into the cancer cells. And once inside the cancer cells, it releases the chemotherapy drug and kills the cancer cells that way. Very sci-fi, but this is really happening in the real world now. So these are examples of antibody drug conjugates that we are using in lymphoma. I mentioned to you earlier the CD30, which is the brentuximab. This is approved in Hodgkin's lymphoma and CD30 positive peripheral T-cell lymphoma. And polatuzumab and loncastuximab, these are targeting the different B cells. This is CD79 is a B cell target. Okay, that's why it's approved in relapsed diffuse large B cell lymphoma. And then CD19 I mentioned earlier is a B cell target. It's again approved in relapsed diffuse large B cell lymphoma. The next way of developing, killing the cancer cells in lymphoma is that we now have better understanding of the biology of the lymphoma cells. What triggers the lymphoma? What happens down to the microscopic level? So this is just one example of a molecular pathway that is associated with diffuse large B-cell lymphoma, what we call the chronic active BCR signaling pathway. So you don't need to know the details. I just wanted to highlight in these slides that there are all these different proteins along the pathway, and these different proteins actually represents an opportunity to target these enzymes or these proteins and to block the effect of this pathway. Once you block the effect of this pathway, you are essentially decreasing the survival of the cancer cells. So for example, in this next slide, I show you the square boxes here in orange. These are the drugs that have been developed to target some of these protein kinases in the pathway of this signaling pathway. So this is another example of how lymphoma treatment has really advanced, and most of these tyrosine kinase inhibitors are actually oral therapy. The unfortunate thing is that you have to take it on a daily basis to actually block it. For example, ibrutinib targets the BTK protein kinase, and this drug is actually taken orally and it's taken on a continuous basis for as long as needed, for as long as it works. So the next part of the talk is on immunotherapy. I mean, this is a buzzword in recent years, right? So what essentially is immunotherapy? I mean, for the longest time, we know that our own immune system can actually kill cancer cells, right? So how does it kill cancer cells? Is essentially based on our T cells. Our T cells are actually cytotoxic T cells, can recognize the cancer cells, like in the first slide, in the first picture here on the left. And in the middle picture, the T cells then attack the cancer cells and then destroy the cancer cells. So that's the very simplistic explanation of how it addresses the cancer cells. It's based on this cytotoxic T cell. So in other words, immunotherapy, the newer forms of immunotherapy that are developed is predicated on this principle. How can we enhance the T cells to then counter the cancer cells? The oldest form of immunotherapy is really this allogenic stem cell transplant, or what we used to call a bone marrow transplant from other people, from a donor. So you're taking someone else's stem cells, put into the patient, and then utilizing the donor stem cell to kill the cancer cells. But we now have newer forms of immunotherapy that I was alluding to earlier. So we have the checkpoint inhibitors called PD-1 inhibitor. We have bispecific antibodies, and we also have CAR T-cell therapy, which some of you may have heard of. So what are PD-1 inhibitors? So remember, I prefaced by telling you that immunotherapy is really predicated on enhancing the T cells, the immune system, to kill the cancer cells. And how do we do it? So the picture on the left here, where PD-1 is linked to PD-L1, when this is connected, this is one of the mechanisms where the cancer cells can actually evade our immune system, that means hide from the immune system, because of the presence of this connection between PD-1 and PD-L1. They are our natural brakes in the system. So what this inhibitor does, what this drug does, is that it unhinges this connection. So this drug, this PD-1 inhibitor comes along and then breaks this chain of connection. And then by breaking this connection, it allows the T cell to be free, to be activated, and therefore able to kill the cancer cells. So that's one way that the PD-1 inhibitors can, that works. So this is one of my patients with Hodgkin's lymphoma on a PD-1 inhibitor called pembrolizumab. So this is before treatment, he had this big tumor underneath his armpit area. And then after treatment, you can see after just 4 to 5 weeks of treatment, it all melted away. Another new type of immunotherapy is called what we call the bispecific antibodies. Earlier on, I told you there was just the monoclonal antibodies, just one type of antibodies. But now they can develop an antibody that can recognize both the target, the tumor cells, the CD20, and also CD3, which targets the T cells. So in other words, bringing the T cells directly into close to the tumor cells, and therefore allowing the T cells to do its work and kill off the lymphoma cells. So that's what it does. Having a monoclonal antibody that can have two connections, one to the tumor and one to the T cells, and therefore bringing about a T cell increase, proliferation, and then therefore the T cell can then do its magic and kill off the lymphoma cells. So there are different drugs that have been developed now as a pretty exciting field that probably is not approved just yet, but it probably will come in the coming years. And the buzzword for immunotherapy is this is CAR T-cell therapy. So this is our first patient in Singapore that underwent CAR T-cell therapy outside of a clinical trial. This was in today's online paper last year, August. So what is CAR T-cell therapy? So again, the simple principle is that you're trying to enhance your own T-cell immune system. So what it does is that people have developed ways to bioengineer the T cells and enhance it, and then put it back into the patient so they can kill the cancer cells more effectively. And how do they do it? So again, we use CD19 as an example, because CD19 is the one that identifies the B cell lymphoma. CD19 is one protein that's expressed on the B cell lymphoma. So in CAR T cell, we have the binding domain, which is the recognition one, and then the signaling domain. The signaling domain is the one that that tells the immune system to produce more T cells so that you can kill off the lymphoma cells. And how do you develop this CAR T cell? It's actually quite a long drawn process, about 3 to 4 weeks. First, you take out the patient's blood and the white cells on the patient's blood. You isolate it. Then after that, you bioengineer it and inserting certain genes into the T cells, and then put it back into the. Basically, you're bioengineering a T cell that is weaponizing it so that you can more effectively kill the cancer cells. And then you expand that CAR T cells, and then you put it back into the patient. And after that, you can see the activity or the effect of the CAR T cell therapy. There are various examples of CAR T cell that are available for lymphoma. The one available in Singapore is the second one, called Kymriah. Yeah. The last part of the talk will be some of the advances in radiotherapy in lymphoma. This is the current radiotherapy techniques. Okay, so the point in red here is the tumor. So the concentration of the dose of the radiotherapy will be around the tumor cells here in red. But unfortunately, when we use current radiotherapy techniques, it also affects the other normal tissues in the other parts of the body, right? In yellow and in green and in blue, in lowering doses. But the focus, the tumors gets the majority of the radiation treatment. But now we have newer radiotherapy approaches like proton therapy. So like proton therapy essentially is, so standard radiotherapy is on the left, the picture on the left, where you shine the radiation through. It will affect the entire normal tissue before and also after. But when we use proton therapy, it only affects the beam before, but it spares the normal tissue beyond the tumor itself. So that's the beauty of using proton beam therapy. It's currently available in parts of Asia like China, Japan, Taiwan. And it's coming to Singapore. We're starting our first proton beam treatment this year. The last part is that on targeted radiotherapy. So again, we now have targeted radiotherapy where we can use a monoclonal antibody, and then we attach the radiation isotope or the radioisotope onto the monoclonal antibody. And again, when we infuse it into the bloodstream, the idea is really to bind to the antibody will bind to the B cell tumor, and then the radiation will then do its trick by killing off the B cell tumor in the surrounding. So this is one new method of what we call targeted radiotherapy. So I just want to end off by some take-home points. So I mentioned to you that lymphoma really is a cancer of the white blood cell. In other words, a cancer of the immune system. There is a rising incidence of lymphoma in Singapore, which is very similar to the developed nation, occurring usually in those above the age of 60. It's not a single disease. It's a very heterogeneous population. There are 80 different subtypes of lymphoma. And because of these different subtypes, the treatment is also very variable. So, but we can broadly define lymphoma into whether they are slow-growing or fast-growing. Slow-growing lymphomas may not even require treatment and can be observed. But if they do require treatment, the chemotherapy is usually less intensive. Fast-growing lymphomas, we have to start chemotherapy immediately. And usually it's a combination of chemotherapy and targeted therapy given together. Again, I went through the several newer treatment modalities. We have like monoclonal antibodies, we have antibody-drug conjugates, we have bispecific antibodies and CAR T cell therapies. So these are some of the newer treatment options that I have shown you this evening. I hope you had it was an educational night for all of you. And with that, I thank you very much for your kind attention. I'll hand this time back to John. John, you are muted. Can you unmute yourself?
Okay, come again. Thank you very much, Dr. Tay. Thank you for the insightful sharing. I believe many our viewers will have actually benefit from it. And now we come to Q&A questions. Okay, the first question comes from Ryan Tan. Her question got two parts, but we'll just mention the first part first. Okay, her mom has diagnosed with angioimmunoblastic T cells lymphoma. What's the question is, what are the treatment options available for her aside from chemo, and what recovery survival rates with this treatment or without it? You're on mute. Now you're, yeah.
Thank you, Ryan, for the question. Angioimmunoblastic T cell lymphoma, as the name implies, is a type of T cell lymphoma. Unfortunately, the treatment option still involves chemotherapy backbone because it's a fast-growing kind of lymphoma. And I mentioned to you earlier that that for fast-growing lymphoma, you need to incorporate both a combination of chemo and also targeted therapy. In this case, you have to check with the doctor to see if CD30 is positive, and then you can obviously add on the CD30 antibody.
Okay, thank you, Dr. Tay. Actually, for Ryan Tan, the following question is that, okay, can the patient wait and see and observe for a period for development symptom before deciding to commence on any treatment?
Yeah, so I mentioned it in the previous answer that this is usually fast growing, and that most of the time there is not a wait and see. I mean, we don't wait and see. We normally will start treatment as soon as we can.
Okay, thank you, Dr. Tay. There's another question from this Sandipati Sahu. Okay, he's mentioned about, is this treatment recognized for non-Hodgkin's lymphoma as well?
Which treatment are you referring to?
But she didn't say any treatment. Okay, maybe we go to the another question first. Okay, this lady from SH Lu, what she says that, may I know the risk of relapse of PTCL stage 1 after 6 course of ECHOP and autologous transplant treatment available for the relapse?
Okay. Yeah, so this is a difficult question because PTCL again is a very broad terminology. So it depends on. So stage 1 generally do better. So I think after having 6 courses of chemotherapy and autologous transplant, there's still a good chance of survival. I think again, we need to subtype it better. I mean, PTCL again is a very broad category, and therefore probably need to know a little bit more detail about what type of PTCL it is. But in general, if it's stage 1, they generally tend to do a bit better.
Okay, thank you, Dr. Tay. Maybe there's one more question I'd like to ask is that, how will lymphoma treatment affect daily life? Will patient be able to work, exercise, or perform usual activities?
Right, yeah. So, I mean, I guess the question was whether after chemotherapy treatment from lymphoma, right? How does it affect daily life or the...
Yeah. Okay, thank you. Okay,
after chemotherapy, the question was after chemotherapy. Could you repeat the question again?
Okay, will the patient be able to work or exercise or perform usual activities?
Okay, yeah. So typically after chemotherapy side effects are generally temporary and they're transient. So most of my patients will actually recover within 6 months close to normal, and they can go back to their usual work, exercise. Maybe in the initial few months, there may be some, maybe a bit slower, but they will slowly get back to the swing of things, usually after 6 months.
Yeah, thank you. Okay, there's another more question from Jennifer Wong. Okay, what she asked is that what is the possibility of slow-growing follicular lymphoma becoming an aggressive lymphoma?
Okay,
So
that's a
if-
very good question. Yeah, that's a very good question. So slow-growing lymphomas most of the time stays as slow-growing lymphomas, the follicular lymphoma. But there is a 10% chance of transforming from a slow-growing lymphoma to a fast-growing lymphoma. We don't really know who will transform, but that's why we monitor them year on year. But there's a 10% chance of that occurring. Your second part of the question you asked, it does not affect. So if no symptoms, is it okay to wait? Yeah, so the second part of the question is if no symptoms, yes, it is okay to wait and see. Very often I do just observe if the patient has, like I said earlier, very small volume disease or no symptoms at all. I actually do opt to just observe.
Oh, okay, thank you, Dr. Tay. We will still look. Wait. Okay, maybe we ask this one last question on this is how long would you have lymphoma without knowing?
Yeah, so for those with slow-growing lymphomas, actually sometimes it can occur for years before you even know about it. For example, let's say it was a slow-growing lymphoma that started off in the tummy, in the abdomen, where it's very hard to pick up if you didn't scan for it. And it could have been there for years before it eventually became a sizable mass before you pick it up. On the other hand, if it's a fast-growing lymphoma, then usually it will declare itself very quickly in terms of months and not years.
Okay, thank you. Thank you, Dr. Tay, for your time. And we have all the questions we have for tonight. So we thank you for your time with us. So we like to say thank you very much and goodbye.
Thank you for inviting.
Thank you very much for all your sharing. Thank you very much. Okay, we come to the end of the Q&A questions. Okay, we would like to have your feedback. So it would be great if you could appreciate your feedback on today's session. Kindly complete the form by scanning the QR code and just text us your feedback and leave your message with us to help us to improve so that we can be better in the next time we do it. Okay, our next talk coming up is the topics on colorectal cancer, understanding the risk and treatment. Okay, the date we have it is by Dr. Sean Yip. Okay, the date is 11th of March on a Friday, 8 p.m. So do join us for this talk. Our next talk will be on the our next talk will be on the 19th of March. Okay, 19th of March is a Chinese talk. The talk is by Bo Guohan 顾问医生 and the topic is in 直节肠癌极容易避免，但是如何开始 ？Okay, remember is 在3月19日8点半，3月19日8点半。Okay, thank you very much for your time and visiting us. So do remember to follow us on our Facebook Live and also giving your likes and follow us. Thank you very much. And also our co-organizer OncoCare Cancer Centre. Thank you very much and good night.